One of the interesting things about the recent management of men with prostate cancer is the realisation that we've been over-treating many men with prostate cancer in the last 10 or 20 years, and there are groups of men that don't need immediate active treatment. I wonder if, Shomik, if you could outline how that's come to be and what we're doing about it.
Well, the thing about prostate cancer is it's often a disease of the elderly. So one particular circumstance where it might be better not to treat prostate cancer as soon as it's diagnosed is in someone who's older or has many medical comorbidities, because old saying goes that men will die with their prostate cancer rather than of their prostate cancer. And so we undertake a process that's often referred to as watchful waiting, where the idea is to keep an eye and if the cancer does become symptomatic, then to treat on a symptomatic basis, but it's often the case that men will go through the rest of their life without needing treatment.
Right.
The other circumstance where often an initial approach of conservative management is appropriate is that prostate cancer, particularly of so-called low-risk prostate cancer, can take a very long time to actually progress or become problematic. And under those circumstances, sometimes in the short to medium term, the side effects of treatment actually outweigh the potential benefit to the man. And under those circumstances, the intent is to perhaps treat those that show signs of progressing or becoming more aggressive, but not treat the ones which remain low risk. And in fact, many men can remain on this sort of a so-called active surveillance program for many years, which we do use increasingly.
Right. So how do we select out the men who it's safe to watch closely and separate them from the man that we need to get on and treat straight away?
There are various parameters that help us in that prediction. Obviously, no prediction tool is perfect, but the sorts of things that help us are the PSA. So the higher the PSA, the more we worry that there may be more aggressive disease. The actual stage of the disease, the grading of the disease. Lately, the MRI findings can be very helpful in that the biopsy may only show us part of the story, but if there is extensive disease, that's evident on scans. The most important thing with these men is the follow-up, because we do want to try and pick when they might go from that sort of low risk disease to a higher risk model.
Right, so what sort of things do we watch when we're doing that?
They will have clinical follow-up, they will have PSA testing, further biopsies are important, and they're particularly done if something changes, but even on a routine timed basis. And again, going back to the emergence of MRI as a classification tool, the use of MRI is now being built into a lot of these active surveillance follow-up programs.
So what we've found is that for most men with low-risk prostate cancer, in fact, active surveillance is the preferred treatment option. And this should be discussed with men and men encouraged to take up active surveillance. But close follow-up's vital, and Shomik, you've mentioned the PSAs, re-examination and biopsies really should be performed, a confirmatory one within a year or so, and then at regular periods after that. We think that MRIs might be able to also show changes that would prompt earlier biopsies, and that's important to watch these now. One of the things that we've noticed in the Prostate Cancer Outcomes Registry, which is a national registry of outcomes for prostate cancer, is that there are many men who have active surveillance as their treatment but really aren't being followed as the protocols would suggest they should be. They are on active surveillance, but the surveillance they're on is not particularly active, and that's an important problem because some of these men, in fact, may progress more quickly than we suspect, and we won't catch them if we don't treat them early enough.
I think that highlights a need for making sure there's adequate information and support, and in particular if men are moving or failing to turn up for follow-up, that there are mechanisms in place in order to chase them up or remind them so that doesn't get missed. One concern that men and their families often express is this safe option, and the fact that there's been a cancer diagnosed but nothing's about to be done can be a source of concern. I think managing that sort of psychological distress and uncertainty is very important. One of the facts that helps that is the fact that studies now out to 10 or even 15 years in some centres demonstrate that over that period up to 2/3 of men remain on surveillance, and those who actually come to treatment in the majority have a very good outcome. So I think it's a very safe alternative for the appropriately selected and supported man to follow.
But the critical thing, I guess, is that the proper surveillance programs are in fact put in place and that men do get the repeat PSAs and biopsies and our follow-up and support to allow them to do that, I think is critical.
Absolutely. So talking about new developments in prostate cancer surgery, we've already talked a little bit about the fact that there are changing selection criteria for men coming to surgery. So low-risk cancers, which going back as recently as, say, 10 years ago, would often have surgery, is now undertaken via active surveillance program. On the other hand, higher risk cancers were quite often not operated upon, partly because it was felt to be futile, but now surgery often forms the starting point of a multimodal approach, and these patients may sometimes get surgery followed by radiation, sometimes with systemic therapy options built in as well. Surgical approaches have also evolved. Radical prostatectomy has now been around for 30 or 40 years, but the conventional open surgery, which still gets done and with good results, is now supplemented by minimally invasive approaches. And this can be done either with standard laparoscopic surgery or increasingly through a robotic approach to laparoscopic surgery. The benefit of robotic surgery in particular is providing additional manipulative dexterity to the surgeon and ergonomic benefits that allows the surgery to be carried out with hopefully greater precision and better outcomes. The biggest benefit to the patient usually is a quicker recovery, less bleeding and blood loss and wound pain, which allows them to return back to normal functioning quicker. In expert hands, all of the surgical approaches seem to yield comparable outcomes, but probably the most important determinant is to choose the approach that is accessible to the patient and allows them to get recovered and back to their normal functioning as quickly as possible. During surgery, there's obviously the prostatectomy. Depending on what type of disease there is, we would often undertake nerve sparing in order to allow good functioning of sexual function post-operatively. However, with the surgical treatment of more higher risk cancers, the option for nerve sparing may sometimes not exist, and the nerves may need to be sacrificed with the prostate in order to get a good clearance of the cancer. The other component of surgery that is often undertaken is lymph node dissection, whereby the pelvic lymph nodes are removed, and this is particularly critical in order to obtain the information regarding whether the cancer has spread there and be as precise as possible with regards to the staging, and it may actually dictate then further treatment, including particularly the use of hormonal treatment to treat systemic disease.
Radiation treatment's also been evolving very quickly over the last couple of decades. We have new technology which essentially gets higher doses of radiation into more accurately defined and targeted sites in the body. So we have new machines and new techniques now that allow us to do that, and some of those are just modifications of the standard linear accelerators that we use, which have made them quicker in delivering the treatment, more accurate and more precise. But we also have additions to the linear accelerators which allow us to see the precise anatomic volumes that we are treating at any one time, and that involves things like CT scanners built into the CAT scanner, or in some cases we use what we call fiducial markers in the prostate that we can watch in real time to make sure that we're hitting the right space. And this allows us to ensure that we can give a very high dose to the prostate and minimise the side effects to the normal surrounding tissue. Other things that we've been doing with radiation machines are to use robotic techniques, and this is a machine called a cyber knife, which has a robotic automobile type machine that automatically follows the prostate and gives radiation targeting the prostate from many directions in a robotically controlled manner. It's a very flash and impressive machine if you can get a chance to look at it. The other thing that's coming in the next decade to Australia is protons. And protons is a technology using a different form of radiation which some people think is going to be a very useful modality for prostate cancer in the years to come. One of the things which has been developing in the last 5 to 10 years in radiation is also the idea of using smaller numbers of treatments. So typically with radiation treatment we've used treatments which go on for 7 or 8 weeks on a daily basis, but we now have this understanding that allows us to give the radiation in much shorter bursts. So the radiation can be given over a period of, say, 3 or 4 weeks. And this is obviously much more convenient for patients, and particularly patients that come from a long way away from the radiotherapy centres. The recent work and future research is looking at even cutting that treatment time down to 1 or 2 weeks. And so that'll also make it much more convenient if that proves to be effective and safe. We also have a new approach called SABRE, which is stereotactic ablative radiotherapy. And that is to use the very precise control of radiation beams and real-time imaging with CT scanners to give very high doses of radiation to localized areas in the body. And this is something that we've been using particularly for patients who have what appears to be single isolated spots of prostate cancer which has occurred in other parts of their body. And this is a very promising use of radiation treatment which in the years to come will possibly be something that's very effective for men who have limited areas of spread disease. The brachytherapy is a form of radiation which has also been improved over the last 10 or 20 years. We now have technique which avoid some of the stricture problems that we had in the past with brachytherapy, and we've become much more accurate with the targeting of the cancer with brachytherapy technique, which is a specialised form of radiation treatment. We have research which shows also different combinations of androgen deprivation and radiation, which improves the results of the radiation treatment. And some men that local doctors might see in their practice will also have spacer gel used with radiation treatment, which is a inert gel which is injected in front of the prostate and behind the rectal mucosa to separate out the rectum surface from the prostate, and therefore reduce the radiation dose to the rectum and make the side effects less likely to occur. This is used from time to time in different centres around Australia.